One model that we'd like to talk to you about before we open it up to questions is a model that a group of us learned about in Memphis, Tennessee, a couple weeks ago, called Memphis Congregational Health Model. And I'm going to invite Suzanne Schlattman, Deputy Director at Healthcare for All, and Reverend Irrance Reddix to come on up and talk with you for a few minutes about this successful model, which we think can be adapted well to Maryland. So, Suzanne?
Reverend Reddix? There you go.
Good morning. Okay, so thank you again this morning for being here. My name is Suzanne Schlattman and I work with Vinny, as he introduced. And this has been a really exciting process for us to go around to different places and talk about really thinking outside the box and how we can improve the patient experience. So hospital payment structures and local initiatives and all on track to be well and stay healthy. But right now, I want you to close your eyes and think about you. Inevitably, you get sick and you go to the hospital and you're a patient. As you're sitting there not feeling well, someone walks in, they greet you, they ask you how you're doing, and then they ask you if you're a part of the Congregational Health Network. You vaguely remember your pastor talking about the Congregational Health Network and signing up after church one day, so you say yes, and then they say, great. Would you like for me to call your pastor, let them know that you're here? Would you like for them to be involved as a part of your care? And that kind of catches you off guard. Your church does stuff like that for people who are homebound or sick, but you never thought it'd be you. So curious, you say, yeah, I really would appreciate having them know that I'm here and care for me when I get home. I don't know how I'm going to drive to my follow-up appointment. So that person from the hospital calls your church and lets them know that you're there. They have a trained volunteer called a liaison who knows how to protect your privacy and attend to your needs. So that person calls you. She may even visit and say, how are you and your family doing? And what can I do to help? The navigator from the hospital comes in and you all work out a community care plan so that basically says when you go home, this is how the congregation can support you and what the hospital will do and who you can call when you have questions. So it feels great. You feel a lot more at ease when you leave the hospital. But you get home and you're a little bit confused about the medications and the whirlwind of the discharge. You don't know where you put that piece of paper that explains it. You don't know where that number is that you need to call. But the next day, the person from the congregation stops by and you ask her, hoping that she was paying better attention than you were during the discharge. And she doesn't skip a beat. She doesn't hesitate. She calls the hospital and gets the straight answer to put you on the right track so that everything is on pace to help you, body, mind, soul, to be on the right track for a speedy, sustained recovery. You like that happy ending? I do. What does that sound like? Care coordination. It sounds a lot like what we've already been talking about, and it sounds a lot like what my church already does, with a few key twists. So what I just described is the Congregational Health Network that started in Memphis, Tennessee in 2006 as an effort to organize and align the resources that are available both in the faith community and in the healthcare system. And it was started by Methodist Le Bonheur Hospital in Memphis, Tennessee. And it started as an initiative to improve population health, especially among those who were frequently coming to their emergency rooms for things that could have easily been prevented with some basic care and support. So what they found was they needed to enter into a covenant with local pastors. They're already talking to each other a lot, going to health fairs, but having a formal agreement that says that the hospital is going to hire staff to directly communicate and work with a person who's trained to protect privacy and help folks with a range of assistance. And those navigators, the hospital staff, what they found could greatly reduce length of stay. They could greatly reduce morbidity, mortality, and readmissions, and they found that working with, training, and providing basic support to the volunteer liaisons, they could really improve patient satisfaction and save the patients and the healthcare system a lot more money. These are themes that we've been hearing about all morning. And this is how they're doing it in Memphis, and we think that it's a really great model for here in Maryland. The congregations who were a part of who still are, I should say, a part of the Congregational Health Network in Memphis really liked this because, they were doing a lot of this stuff, but on a less organized level. They would have people from their congregations coming to them with questions, and then they'd have to call through a whole slew of different numbers to not find the right answer for them. They just didn't have the time or resources to do that. This gave them, they really liked having that one person that they could call to get a quick, direct answer, or at least, I'll get back to you right away kind of an answer, and they found that it helped them deploy their ministries and their limited resources much more effectively and efficiently, and in a way that helped everyone feel a lot better about the process, while also protecting the privacy and dignity of members of the congregation and the community. So to date, over 600 congregations have entered into this covenant with Methodist Hospital, and they are serving 20,000 actively engaged Congregational Health Network members. The hospital says that it spends about $600,000 a year, and most of that comes out of their their community benefits, and it goes through the salaries for the navigators and training for liaisons and other expenses like mileage. But the hospital also says that this program alone saves them $4 million every year. So they're really reaching the people that they need to reach and really tapping into these volunteer and existing resources that are in the community to help them have a greater impact. And we, again, think this is a great model that we could use here in Maryland, especially under the changes in the delivery system that we've been talking about this morning. So our role in this, the Healthcare for All, is working to just raise awareness about this is a great thing and that we have the great assets and the need that can be aligned under this model. And we have some reference materials for you in the handout. I know we didn't show you, but this is a great diagram kind of when you're talking about it with folks who are interested in being involved that you can use. There's also a sample of the Congregational Health Network card that people sign. It's kind of like a HIPAA form. And the covenant that the pastors and hospitals drafted together in Memphis. We're not saying that this is exactly what we would use here in Maryland, but just gives you an idea of what it looks like. We also have a sample of the Congregational Care Plan, or Community Care Plan, and that you can also look at, again, just as a model. And we also have a few copies of a white paper that we worked on following our trip to Memphis that goes into a lot more detail for those who are interested in more resources. But right now I'm going to turn it over to my colleague, Reverend Dr. Irrance Reddix, and talking about her perspective from why this model got her attention both as a doctor and as a member of the congregation, as a minister. So without further ado, I'll pass it on.
Good morning. Mine is short and sweet. I'm a physician and I'm also a pastor. So I'm just telling you that this works. I became interested in the Memphis plan because I began researching actually chronic disease. Most of my patients have chronic disease, hypertension, diabetes, HIV care, and lack of care. And as a pastor, I'm realizing that my patients and my congregation look so very similar. And as you start to look at your congregation, you realize when people aren't there and you ask what happened, you find out that they're in the hospital. You don't know that they're in the hospital, and by the time they get back to you in their congregation, they've had all of this healthcare experience and none of the healthcare support. I won't say none, but very few of it. So this model that we're proposing now is a way to support them, not just physically, but mentally, emotionally, and spiritually. Because this healthcare Congregational Health Network plan allows us to close the loophole. I come speaking to you just on a perspective of saying that it does work in Memphis, and now we're realizing it's working in Wake Forest as well. It is decreasing morbidity, mortality, and saving healthcare dollars. On a very pragmatic point of view, which is what I'm closing on, what happens is the pastors and the and the bishops and the priests and all of us, we speak to each other in this language of how do you keep people healthy. You speak to your congregation and say, hey, why aren't you here? We need help. Are you taking your medicine, etc., etc. We're asking them to take care of themselves, which we've been hearing all morning, but not giving them the tools to do so. When they sign up for the network, they will find that they have another support. So when they do go even to the acute care or to the hospital, there's someone that will come and see them and help them navigate through the system. If they find themselves hospitalized, they find that there is someone there who will come and see them. Most of the liaisons and most of the navigators will see them at least once or twice after the hospital stay, and definitely right before they get ready to have a discharge. They're part of the discharge team. You will then find that your faith leader, whether it's your priest or whether it's your pastor, will also be part of the team. They may not physically be there, but they know what's going on. So when they come back either to their house or to their congregation, and they say, I don't know what I do with this piece of paper, I have the medications that's different than what the primary care physician is, then they have that other layer of support and care. And they found that people get better faster, they stay better longer, and the community as a whole, that's the one thing Suzanne said, but said quickly in your paper, that the whole community gets better. Because once that person goes back to their home, they live in a community. And they then tell, this is what happened to me. This is what happened to my pastor came and saw me. Oh, I don't have a pastor. That's fine. We'll still come and help you. They can still be part of the Congregational Health Network, even if they don't have a church or a synagogue. And so this is one model that helps close that loop. It is part of the care navigation system, but it's the part of the system that is personal, like friends. Somebody knows your name. So please read the information that's there. We've been working on it for at least a year or more. So there's a lot of layers, there's a lot of information. And after the question and answer, you can ask us these questions, but it's really something that you need to think about, because most people are close to a church or a synagogue or a mosque or a community center. And we're just using our health assets that are there.